Hello, welcome to the final Lancet Voice of 2022. I'm Gavin Cleaver, and we're very pleased to have you with us again. Today, we're handing over the reins to Taissa Vila and Elisa Pucu from the Lancet Regional Health Americas, and you're going to hear them talking with Professor Felicia Knaul. Professor Knaul is Director of the University of Miami Institute for Advanced Study of the Americas and a Professor of the Leonard M. Miller School of Medicine. Taissa, Elisa, and Felicia are going to be discussing the lack of gender diversity in medical leadership in Latin America and the gap in evidence of gender dimensions of the health workforce and how the majority of unpaid healthcare and caregiving is provided by women while men occupy leadership positions. This is all based on Dr. Knaul's piece in the Lancet Regional Health Americas, which is entitled Feminization of Medicine in Latin America. More the merrier will not beget gender equity or strengthen health systems. I hope you enjoy. And I hope you've enjoyed our 26th episode throughout 2022. We look forward to seeing you in 2023. For now, here's Taissa Vila and Elisa Pucu talking to Professor Felicia Knaul.
Hello, all. I'm Taissa Vila.
And I'm Elisa Pucu.
And we're delighted to have Dr. Felicia Knaul with us today to discuss a piece she authored and published in the Lancet Regional Health Americas entitled Feminization of Medicine in Latin America. More the merrier will not beget gender equity or strengthen health systems. Dr. Knaul is the director of the Institute of Advanced Studies in the Americas and professor at the Miller School of Medicine at the University of Miami. She is also a senior economist at the Mexican Health Foundation and founding president of Tomatolua Petro, a Mexico-based NGO that promotes research, advocacy, awareness, and early detection of women's health issues in Latin America. She has dedicated more than 3 decades to academic advocacy and policy work in global health, focused on reducing inequalities and improving the condition of vulnerable groups, especially in Latin America and the Caribbean. So welcome, Felicia. We're delighted to have you with us today.
I'm delighted to be with you. It's amazing for our region to have this journal and to be able to be, part of helping to think through how it can promote health policy, reduce inequities, and really support also our researchers and early career researchers in the region.
So for the first question, could you please explain what the idea behind the piece and where did the inspiration to write about it come from?
So there's actually a bit of a history to this. The first piece goes back to 2015 of that history when the Lancet put forward a very innovative commission on women in health led by 2 colleagues and friends, Anna Langer and Afaf Malaise. And in that work, we looked at a model that had been developed by Julio Frege, which is all the different ways that women and health interact. So not only looking at the health of women, but women not only as consumers of health and healthcare, but also producers of health and healthcare. And in that report, we were able to demonstrate how important it is to look at the gender aspect and to show, I think probably for the first time, that the majority of health and caregiving is produced by people who identify as women. It was sort of no surprise that caregiving is majority provided by women, and we can talk about that in a bit. But it was certainly quite important to identify that the majority of paid people who work in the health sector are women as well. So in the end, it's about the 70% is like at the key number, and we're actually just completing an update paper that we hope to submit to the Lancet soon on this. So like the magic number is about 70. It's about 70% of hours. It's about 70% of those who produce healthcare, and it's about 70% of the total value. And when you add it all up, the number that we shared in that report was over 5 trillion and over 3% of global GDP. And our new estimates, they're significantly higher than that when we include discrimination, and somewhere between 8 and 11%. So just a huge subsidy to the health sector. But what also came out in that, and I think we'll speak about it later, is that there's tremendous underpayment due to discrimination and lack of payment for all of the healthcare that's provided particularly by women. And that undervalues the whole sector itself, health and caregiving. But I want to take it sort of back a couple more steps because, we are speaking about Lancet Regional Health Americas, thinking about Latin America, that it was actually work that I undertook arriving in Mexico in the early to mid 1990s with my husband, Dr. Julio Frank. So Julio had done some of his thesis work on under and unemployment of physicians in Mexico. And he had shown, which is this really very important point at the time, that there were just a plethora of Mexicans without health care and also doctors without work, right? And it was about 30% of physicians. And then when we started working together, I asked the question, what about gender? And it turned out that the vast majority of those physicians that were without work or were qualitative or quantitatively underemployed were women, overwhelmingly so, well over double the rates that we saw for men. And that led to a whole stream of research. And it turns out that it affects nursing and many other careers in the health sector, where what we see is that gender, particularly being a woman, clearly implies a whole set of barriers. But I think what's so key for us in terms of policy is this idea, particularly we saw during the pandemic and post-pandemic now, that we have so many people in our world and in our region who lack access to healthcare. And part of that is a lack of human resources to produce and deliver that healthcare. Yet a good proportion of resources are there and under or unutilized because they sit with women who don't have ways to work in our health sectors that are dignified, decent, and allow them to have a work-life balance. So that's why we did this paper. And I think we have something about Latin America, these data, that we have to project and ask globally.
Yes, absolutely. And since you already pushed it to Latin America, my follow-up question is, do you look in your work about what is it specific to Latin America that makes gender inequity so persistently present? Is there any difference comparing to the whole world and what's behind that?
It's a great question. I've been thinking a lot about this. I think that one of the terrible constants that we have in our world as an constant over time and over space is discrimination against women, discrimination based on gender. So I don't think we can say that is unfortunately or fortunately unique to our region, to Latin America. But what are some of the differences? We have seen an incredible increase in female labor force participation in our region that in some countries is higher than anywhere else in the world. We've seen incredible increases in educational attainment and, near parity, if not beyond parity, of women who study in certain professions, including medicine. And as we showed in the paper, somewhere around 2019, we end up with more women studying medicine than men. That isn't a constant throughout the world. So what does it say about our region is that we have an incredible potential to solve this problem, but also a really pressing need to put in place the gender transformative policies that are required in medical education and overall in the health sector, but also in how we manage and incentivize the time of families, men, women, and others to provide childcare, to be able to ensure that this population has appropriate access to care. Not all regions in the world can boast that opportunity as yet. We have that. It means we have something we can do for ourselves and something we can, I think, use to project elsewhere. The other that sadly characterizes our region is that it's one of the most inequitable in the world and includes some of the poorest countries in the world. We go from Haiti to Chile, and within countries, we have places that are as poor as anywhere else and deprived as anywhere that I've seen anywhere in the world and in the poorest countries of the world. And at the same time, areas that are able to provide medicine that rivals, and I say this as someone who has battled cancer in Mexico, rivals what you can get in Boston. Those inequity belie opportunities, but also the moral compass that we have to use to evoke change. And I think gender, women, medicine, healthcare is absolutely essential. And just, again, to highlight, we're talking about a paper that focused quite a bit on medicine and physicians and doctors, but this belies the entire health sector. It's about how we treat nursing as an occupation. It's about how we pay our nurses. It's about professionalizing that nursing. And it's about having many, many nurses who don't get to work as nurses and work as anything else, from nannies to taxi drivers to being out of work. So it's really pervasive throughout the entire sector.
It's a complicated issue that throughout the whole region. And I would say it's even more cultural. I can add this. So following up in the opening paragraph, you talk about gender-focused transformative policies that can contribute to strengthening health systems, achieving universal health care. There is coverage that is so important in our region. And could you tell us more about how you see this connection, how those policies could come into play?
Yes, absolutely. Let's and we can get back to your point about culture, which, as long as both of you are willing to also share, as women who identify as women who live in Latin America, because you're living it and can walk the talk, then we can talk about culture, machismo, and other points. But going back to the policies and universal health coverage, let's start with caregiving, right? Which women who are professionals, women who are physicians, women who are nurses, are also overtaxed with the caregiving responsibility for children and for the elderly. And I should probably have mentioned this when we said something about Latin America as well, that this is a region where epidemiologic transition and demographic change has been rapid and extremely compressed. So we see this generation of women who are becoming highly educated, for example, as physicians, and have the responsibility still overwhelmingly for both children, but now also for those who have chronic and non-communicable diseases, and for an older population often, in countries that have just really not done very much to think about caregiving for those populations. Some have done something on childcare, very, very few. Costa Rica, for example, might be one of the only have significantly put in place policies to deal with caregiving for chronic and non-communicable diseases and the older generation. So the first point in terms of gender transformative policies is something that isn't specific to medicine, but includes medicine, which is to try to build in the incentives to be able to provide quality caregiving, which means it includes training, for example, but also to incentivize people of all genders, men, women, and other, to have the opportunity to both work and to provide care. And we talk about that actually in the Lancet Women in Health Commission, because I really do believe it's an opportunity. In many cases, men are penalized more in the workplace if they do caregiving than women. We need to incentivize both and make sure that this is considered a part of life for everybody who would like and wants to provide caregiving for their own families or for their communities. So I think that's one. And, there are a set of incentives that can be put in place. Paid leave, not only for childcare, but also for care of the elderly or those who are suffering from illness. Okay. Then I think we need to talk about the health sector itself. And let's, think about medicine for a minute. We've seen a change over time in the demands that are placed on students of medicine for the number of continual hours that they serve in internships and residencies. But it's still not easily compatible with having a family, and particularly if you're still taking on the majority of the caregiving burden. So what we can do in terms of applying a gender lens to medical education, I think, is hugely important. And then there are a series even of issues that have to do with producing the tools that are required so that women can effectively provide care. And, mentioned in the paper, even during COVID, to be able to have the sorts of protective equipment that would fit a smaller body, that would be appropriate to people typically who have a different body structure than many of the dominant men in a particular profession. And I think all of those, from the largest that affect the entire population to that should be very specific to interoccupational or intraoccupational needs, is what we need to think about when we think about changing policies in ways that will counteract what we're seeing throughout the health sector. The others, we talked a lot about in this paper about stewardship and leadership and what it means to have the majority of learners being women, but the vast majority of leaders being men. And one could say, why is that important? And I know we'll talk about this a little bit later, but it is quite key to think about the policies that are required to ensure that leaders are gender balanced as well. I think that's quite essential. Now, the other piece, if we have a few moments to focus on it, and I produced with some colleagues, including Anna Langer, Beverly Essie, and others, a piece of work, a commentary on universal health coverage and packages and the gendered nature of health and caregiving. And this is quite a fundamental critique to what I think global health leaders have accepted as a very progressive and dominant paradigm for the future of health systems, which is we should all strive for universal health coverage. We should think about progressive universalism. We should take these cost-effective packages very seriously. But when we thought about it a bit, all of that is based on a lot of free or underpaid labor. What makes many of these packages cheap is the fact that you have community health workers or nurses or underpaid physicians and unpaid caregivers in the family who are overwhelmingly women. If we valued, as we should, that care appropriately, which would also ensure that we develop the policies that are required to improve, for example, the training for that kind of work, then these packages wouldn't be nearly so cheap. They're cheapened, it cheapens healthcare, and it cheapens women in a way that goes beyond health. And I think we have to take a very fundamental look at why Best Buys are so cheap, why packages are so cheap, and within universal health coverage, to what extent we're relying on under and unpaid labor as part of the feminization of the health workforce, beginning with physicians.
I'm personally very keen on the studies on unpaid work for women because we don't talk enough about that and about not only when we think about universal health care, but if we start to critically read many or possibly most of the policies that we have in health related, if we're sticking to this topic, we'll see that they are overwhelmingly not considering mostly women, because we know it's women who do that, but unpaid healthcare provision. And my tricky question to you on that point is that there's a link between who we are forming as teachers, then who we're putting as leaders, and who makes that study that turns out to be a policy. And changing this vicious cycle is a one-way out for us.
Without question. I mean, this is why I was mentioning this idea of learners and leaders and building, a little bit on a recent follow-up paper to another Lancet commission on health professionals for the 21st century that came out in November, the follow-up paper to that, led by Julio Franken and Lincoln Chen, that offer us a whole series of lessons about transformative education post-COVID pandemic, taking advantage of technology to be able to think about the wonderful and impressive ways in which we can increase access in the post-pandemic world. This, and I have to know that this can't be said in a way that takes away from the suffering and loss that so many families in our region, because our region is so heavily affected by COVID, in so many ways that loss is there and it's real. That, however, needs to, and doing justice and almost dignifying that means taking advantage of these new opportunities with technology to be able to provide more and better care in the future. It is really key. And that new paper talks about that. And my question is very much around, well, how can that help us to close the divide between women and men as learners and as leaders in our health sector. And Latin America, again, can be a beacon of figuring this out. Right? Now, why does it matter again? The leaders are overwhelmingly men. While many are enlightened and very able, willing, and I would say determined and dedicated to promote gender equity and equality broadly within our region and globally as well. It is different to live it than to just learn about it. Right? And so I think we do need to have a balance. And I think as our world comes forward, that balance is really going to be a gender balance. Today, we talk very much about women and men. It's going to be a different gender conversation as we go forward. But the point is to have leaders doing the research, leaders implementing and making the policy decisions who have lived and understand what it means to embody certain experiences as they practice their profession, medicine, as they speak to patients who are women and of other genders and work with those patients, and as they seek to think about how education needs to move forward. The other is, and this is very much an economist point of view, I'm not an economist in many ways, certainly not very neoclassical or conservative or traditional as an economist. One thing that I do believe in very strongly is that we want to have as much talent to draw on as we can. So one of the economic arguments as to why discrimination is bad is that it really limits your talent pool. It limits the diversity from which you can draw new knowledge, new experiences, and new ideas to move all of our societies forward. If you take any segment of the population, ethnicity, religion, gender, color, and leave them out, you lose access to an incredible body of talent that can help that group and all others to move forward as a society. And I think that's what we're doing in the health sector by not recognizing that we are underpaying or not paying at all women who have studied to be able to close the divide in access that we know characterizes Latin America and many other parts of the world, if not all parts of the world. I'm not sure if that answers your question.
So I was thinking in here about the female leading roles and how you talk about women not being nominated for ministers of health. And this is a problem in our region, I have to say. And I think it's really tricky to try to find this balance here in our region and to really change this situation and make them be more highlighted. So when we think about the pandemic and how women were affected, they could be transformed and nominated to leading roles. So can you explain even more about this? About how could we change this in our region?
I can try at least. So I think there are two areas that maybe we haven't looked at enough, and we do look at this paper. One is the leadership of medical schools and universities. And these were actually very easy data to come by. They were publicly available. So we were able to put them into a Viewpoint. And we were able to show that this is where we knew that the leaders of education were not gender balanced compared to the learners, right? But we also knew that ministers of health, national and subnational, are often drawn from those who are deans of medical schools or leaders of universities, and that those who have been ministers or leaders in a health sector and the political scene will often go back to a position as a leader in an educational institution. So being able to insist with our educational institutions, some of which have a very long history, like the UNAM in Mexico, the National University in Mexico, and yet have never appointed a woman as dean or president of the university. So I think this is an area where we can drive and insist on change. And it's also where we can depend on our students, right? Students today, and I say this from the University of Miami, sitting here at the University of Miami, they do have a voice. Okay? They may not be undertaking the election, but they're often and more often like sitting within the groups, at least having a seat at the table, saying, what do we want from our leaders? What kind of a fairness selection do we want to be able to have when we think about new deans and leaders of universities? And so there's a voice for our students to insist on more gender transformative policies and leadership in the education sector as well. Now, the other is, and this I wanted to do this analysis for a long time. And so I'm so grateful that Lancet Regional Health Americas let me do this. Years of living in Mexico and going to visit the National Academy of Medicine. Before I was elected as a member, which is relatively recent, I would go, as a visitor when there was a presentation or when there was a particular event, and including when my husband was secretary. And I would go into this amazing room. I mean, it's a beautiful room within one of the areas of the Mexican Social Security Institute, huge room. And there's this enormous wall, right? And the profiles, the portraits of the presidents, like go back to the 1800s, right? I was looking along this wall, and I mean, there were men, members of my family, people I respected. My own physicians were up there, and not a single face of a woman, like rows and rows and rows, and not one woman's face. Now, recently, just a few years ago, they did elect a vice president and then a president, the first woman in the history of the National Academy of Medicine. But I was just so struck when I got there and saw that wall. And I thought, how is this possible? It was just such a gendered environment. And gradually there were more women coming in as, academics into the National Academy of Medicine being elected in, but not in the leadership. And this turned out to be true across Latin America. And again, these were data, these were not hard to get. They're publicly available. And it's just shocking that we have institutions that go back sometimes hundreds of years and have never had a leader who is a woman. And we're, somewhere between 5 and 15% now are women. But why do we care about that? You could say this is really somewhat an outdated institution, perhaps, but it's not. It is also where groups come together to socialize, to talk to each other, to identify opportunities, to be able to say, there is a deanship open in this university. We are looking for a director of a hospital in state X. Right? That's where people come together and talk. That's that social network that really is important for being able to push careers forward. And women just weren't there. And we need to open that up without question. So I think there are some spaces within the health sector that aren't usually thought about. It's not just how many ministers of health do we have. It's how many deans, it's how many presidents of universities, it's how many academicians in our national academies of medicine. And I would also say we need to think at the subnational level, particularly in our region, and particularly in our largest countries, right, in Brazil and in Mexico, where some of the states are the size of countries in our region and in our world, frankly. And so there is a concentration of need and a concentration of power that's important in the subnational level. And we also need to look, it's not just who is the national minister of health or who is the president of the national university. It's state by state to evoke change. And I truly believe, particularly post the pandemic, that we need to think in our region about subnational leadership and change as well as national. And more as things evolve politically in our region, I think that subnational can be a beacon of change, a catalyst that can sort of open a space, break through a glass ceiling when we need it in gender and in many other issues.
If we think about, there is a huge gap on the physicians that we know, but your work showed us don't have problem in forming physicians or forming nurses. Our gap is exactly putting your foot out the door of the university and getting to a leadership role. This is where our problem is. But then if we go back to teaching, how many teachers that were lead of the departments that you had that were a woman. So even that, if you look at, and it's like a first step in your career, you were the, department head. And already there, you just see that they are overwhelming men. So we do need to change the university level, and then we can change dean level, and then we can move up. And I'm just curious to see, do you have any concrete things that you'd say, Taissa, tomorrow, if I could change this in University of Miami, this would be a policy that I think would make change?
Well, it is a bit of a vicious circle, actually, right? That if you, because I think we are seeing change in our region at the level of department heads, and even more balance in under and underemployment, that women are doing better over time from the data that we're beginning to see. But the vicious circle is that if you don't have also gender balance in the higher levels of leadership and stewardship, then what women need to do to get there is even more difficult. Like, we know things like women end up taking on more administrative tasks, and women end up working many, many more hours than men when you think about unpaid work and paid work. And one thing I say to my students now, I don't know if this can change tomorrow, but it can change with how our students look and demand change, right? So, when I was a student and thinking about going into the labor market, I was like, you can be superwoman and you can do it all. You can work longer hours. You can have everything you want in your life. It's not a limiting factor. You don't have to give up your career in order to be able to have a family. You can do it all. Well, yes, we can, as long as we don't want to sleep, right? As long as we don't care about our own health, of course we can do it all, right? So I think we let societies up very easy in saying, we can be superwomen. We can really do it all. That maybe that was step one, but step now is for our students and early career professionals to say, yes, we can do it all. And we want to share in the joy of caregiving and the responsibility of caregiving, as well as in the labor market. And I think that our students and our early career researchers and professionals can actually insist and demand that. That's sort of one. Other things that we can do, something the Lancet is already doing, which is really amazing, which is that we have to not accept in our conferences, in our selection boards, or in anywhere else that we're making decisions or presenting ideas, that we have one single face, right? That looks very male. We have to change that. Now, we haven't mentioned it, but I think it is really important to do so, that it isn't only about women and men. There's an intersectionality issue, right? There are different faces of women and different faces of men, as well as other genders. But mostly what I'm speaking about is being able to have diversity of representation of those that we represent, those who are in need of the care that we can give or that can be given, right? And so we need to think about that intersectionality as we're thinking about gender in terms of change. And that is something that I think has been a very painful set of discussions and realizations in the United States, but it is beginning to come forward. I'd ask you to also comment on whether or not we're there in Latin America. I'm not so sure we are. I think we, too often accept that most of the faces we see on the podium in the National Academies of Medicine or presentations are pretty light and pretty male, and that we need to think about how to change that as well, more than we have been doing in the past. But to sort of go back to your question, what would I immediately do is, and try to in our global health classes, incentivize our students to demand better, demand more, and for all of our students to think that they can demand the right to caregive as well, to be part of their families, or as I said, their communities. They may not be their own family members, but caregiving and being part of creating a society that's healthier isn't only about having a child and caring for one's own child. There are many other aspects. And how do you build in the possibility of all people being able to have that opportunity and give that gift, I think is really important in making our societies much healthier places to live in and to be in.
And important to address as well. I was thinking here and following up a bit on Taissa's question and the cultural aspect that we mentioned before. And I think it's really important to address because culture is part of the society, and we know that machismo is present, very present in Latin America. And that it's a structural problem. We know that there is structural racism, there is structural machismo as well. So should we start at universities as the person who worked with education before? I think it's something that should start at early age and try to develop changes even in a society level. And as people who are healthcare givers and work with health, can we try to change a bit those aspects of the society? Can we do that in a cultural level as well? Change a bit the last question.
Well, and also I'm going to let both of you also comment on this as women who live and work in Brazil. Right now, I straddle Mexico and Miami. But so I also, I would love to hear your opinion on this. But I thought we might bring up one point that I think is absolutely fundamental, which is violence against women and violence against children. And as you might know, we are blessed to have a Lancet Commission on gender-based violence and maltreatment of children that I am honored to co-chair with Dr. Flavia Bustreo. And why do I bring this up now? I can say we have to think about changing textbooks and educating in a different way from primary school on, even from preschool on. But the other thing I really want to say is that while we are talking about at least 1 in 3 women who have suffered serious physical, sexual, or verbal abuse, well, we're talking about at least 1 in 5 children, and in poor areas, much more than that have also suffered severe forms of abuse. There is almost no way that we can speak about change unless we look at that. I think it's a driving force. It's a determinant because there's the intergenerational transfer of violence. A young boy sees it, learns it, and very sadly, too often applies it. There's some amazing research about how to change that process. And Gary Barker, who was featured in the Lancet region very recently, has done really amazing research on this in Latin America, particularly in Brazil, on how you change and break that intergenerational transfer of violence. But let's just talk about the children and the women who have lived through this. All of the evidence shows that no matter how you try to power through it, no matter how much support we can offer in terms of treatment, it affects your ability to study, your ability to work, your ability to live. And so you never are able to achieve your full potential when you've gone through something like that, because at the very least, you have to invest an immense amount of your time in work to alleviate that kind of trauma, right? At the very least. And that's the very, very, that's the best scenario that we can speak about.
If you survive.
If you survive, exactly. And if you get help, right? And we're talking about intense amounts of support, psychological, psychiatric, physical, and others, to be able to re-enter the labor market, to be able to complete school, to be able to undertake testing, to be able to be in an environment with aggressors and abusers often. Almost impossible. Not impossible, almost. But we can change this. There is sort of no other risk factor other than air pollution, I would say, that affects as many people in our world as violence against women and children. And it is rife in Latin America. When I did my doctoral research with street children in Bogota, I was shocked is the understatement to just hear the standard practices to teach children how to behave in certain ways, boys and girls. And we dealt with the tip of the iceberg, what happened as a result, which was, what do we do to support street children, right? But what did we do to change the situation in their homes? And this is where I think so much can be done with communication, and particularly what we can communicate today. We can communicate the message that this is not a way to educate children, that this is not a way to teach or train. And this is completely unacceptable behavior in our societies. And I think the more we can share that message, the more we can change a culture of something that we've called machismo, almost in its least awful form, but that has affected the lives of women and children in our region in unthinkable ways. And we're trying to do research on this now for the commission, but I think that we can explain a significant amount of the gender wage gap, at least the pre-market gender wage gap, because of violence against women.
I tend to think that because we normalize machismo as part of Latin society, we call Latinos, or machismo is intrinsic to Latin society. It sometimes feels to me that we started to accept violence against women as a definition of machismo and a definition of society. So maybe just by normalizing this word and giving it like a sense that it's not so bad is already terrible. And it's something that we should start from there. Like, let's not use this word anymore because it's making something unbearable, like it is okay.
See, it's interesting. When I am all my time in Mexico, I was struck that, and my girls use this word all the time, that something that's really neat is padre, right? The father. Like padrísimo is something that's really cool, really neat. It's, father-like, padrísimo. It's the male. And the word madre can be used either very positive or extremely negatively. But from the time that kids are little over Mexico, they say things are padres, things are padrísimo. And I always say, no, they're madre and they're madres. It really is part of our language, right? And what becomes entrenched through language as being good, bad, or acceptable. So I completely agree with you. And if we go back to medicine and the medical profession, we do have evidence that there's harassment and discrimination and abusive language and inappropriate behavior, all through the medical profession. We also know that things like when we send particularly our young female students out to do their social service, they're often at tremendous risk, right? There is no protection for them physically or otherwise where they are. We will not achieve real change if we can't make safe environments for women to be able to work.
That's really important to address because, like you said, we are both from Brazil and we see the differences in treatment among men and women. We suffer gaslighting and other machismo issues that happen all the time, not only in the medical community, but in research and in education as well. And for example, a difference that we can see is the amount of time on paternal leave. So a father can have 5 days of paternal leave and a woman 4 months. And we know that according to WHO, they should breastfeed up until like 6 months, at least for 6 months, at least, not until at least. So this starts at early in the beginning, and we see girls that are ashamed of menstruating and other problems as well that surround this whole issue of having these gender inequalities in the region.
So long as women have access to leave to care for children and men don't, women are going to be underpaid compared to men. Right? And I've had people say to me, that I know that woman X will take time off. And man Y will not. And therefore, we are going to hire man Y, especially if it costs us the same to do so. What will equalize that and allow us to have a balance between, I said, the joy of caregiving and the opportunity to work is having that be a gender neutral policy in terms of access. Breastfeeding isn't gender neutral, but we can facilitate it in different ways. And we can include access along a period of time that we link access for women to access for men. I think that's the only way that we're really going to evoke change. But that has also to do with valuing caregiving. Like, so long as we don't value that, it's going to be hard to ensure that employers are forced to give to all those opportunities to be able to undertake caregiving. And I mean, I agree with all that you're saying, and this is why I think we can, from medicine, do something very special.
Well, Felicia, thank you tremendously. It was really, really nice talk. And thank you for unpacking your amazing amount of work and connecting all the dots for us. It was really good.
Thank you. And the same, I'm so pleased that we have now a Lancet for our region, the Americas, and that we can have this outlet for being able to publish and change through the Lancet for the Americas, and particularly for Latin America and the Caribbean. And I'm really grateful that both of you are leading this journal. That says an awful lot about what we can do to evoke change. So thank you for all you're doing, and for being partners with those of us who do research in the region. I know, and I hear it from my colleagues and my students, but we're so excited to have this opportunity.
That's it for this episode of the Lancet Voice. If you want to carry on the conversation, you can find Jessamy and I on Twitter on our handles @Gavin Cleaver and @Jessamy Bagenal. You can subscribe to the Lancet Voice if you're not already, wherever you usually get your podcasts. And if you're a specialist in a particular field, why not check out our In Conversation With series of podcasts tied to each of the Lancet specialty journals, where we look in depth at one new article per month. Thanks so much for listening, and we'll see you again next time.